We're very pleased and happy to have Dr. Goldenberg as our next speaker here. Dr. Goldenberg is a fixture in the cardiology scene here and is a recipient of his Bachelor of Arts in Psychology from Temple University. He received his MD from Creighton University and did his medical internship and residency and his cardiology fellowship at Temple University in Philadelphia. He currently is a clinical cardiologist for Christiana Cardiology Consultants, and he is a clinical professor of medicine at Thomas Jefferson University. And Dr. Goldenberg is an expert on lipids and is going to share some of his expertise with us, talking about lipids and stroke, the 2016 guidelines.
Thanks, Lee. I always kind of chuckle when I get introduced. Now I'm being introduced as a fixture. I guess the next stage will be I'll be lying in my grave. I'm not sure what they're going to introduce me as. But thank you very much for having the opportunity to present today, and also to give me the opportunity to rethink about the use of lipid-lowering medications in stroke. These are my disclosures. Somebody once told me that I ought to tell you what's important in the beginning, and then you can fall asleep and we'll have gotten the essence of what my talk is. So this is the summary that points that I'd like you to take home. One, there are two types of stroke with different risk profiles. One is a hemorrhagic stroke and one is an ischemic stroke. Atherosclerosis is a diffuse process and not limited to one vascular system. Statin therapy is effective in primary prevention of stroke, and statin therapy is effective in secondary prevention of ischemic strokes. Well, it's been quite a while since I've reviewed the use of lipids. This probably predates Lee's beginning of this particular symposium. It was actually, I gave it to Grand Rounds in Neurology, and it was probably about 15 or 16 years ago that I had this opportunity. It's hard to believe that just 15 years ago we had to convince people that use of lipid-lowering drugs would be effective in treating people with cerebral vascular disease. It was about 4 decades ago when I started practice that we thought an LDL cholesterol of 180 was actually relatively normal. That's probably because we didn't have too many drugs to treat them. Well, this is why 15 years ago we had to decide whether the use of cholesterol-lowering medications may be effective or not effective. And this was a study that looked at total cholesterol versus adjusted stroke rate. And you can see that, in fact, there does not appear to be any correlation between the level of total cholesterol and the adjusted stroke rate. You have to remember that stroke presents the same. It doesn't matter what the mechanism of the stroke is, that the clinical manifestations are generally the same. And I'm sure you're all familiar with the FAST concept. In cardiology, when you present with discomfort in your chest, the first thing you tell people is to call 911 and chew an aspirin. But of course, in stroke, it's just the opposite. Call 911 and don't take an aspirin. And that's because there are two different types of stroke. There's a hemorrhagic stroke, in which case if you took aspirin on the way to the emergency room, you're liable to perhaps make the stroke bigger. And then there's the ischemic stroke, where perhaps aspirin would be of benefit in decreasing the size of the stroke. I'm not going to go into the acute treatment of stroke, but obviously there's different types of treatment depending upon the type of stroke you have. Well, for many years we were rather myopic, looking only at the central nervous system and forgetting that the central nervous system also was part of a patient. You can tell this picture was taken quite a few years ago, since I don't have a beard, and I was probably 10 pounds lighter. But you have to remember that the cerebral vascular system is part of many other vascular beds. And in fact, people with cerebral vascular disease, about 1/3 of them will have either coexistent coronary artery disease or coexistent peripheral arterial disease. So stroke, although it may be the initial manifestation, is really an introduction to the medical practitioner to realize that there are other vascular beds that may be in jeopardy. Well, Although we focus on stroke, this was a long-term survival study from the Dutch TIA trial that showed that over a period of 12 years, the yearly risk of stroke decreased. However, vascular events continued to increase, and in fact, mortality continued to increase. So there's more to the stroke patient than just the central nervous system. When you actually look at what the vascular events were, 28% were non-fatal strokes, 11% were non-fatal myocardial infarctions, but 62% of the people who went on to develop a vascular event actually died from the vascular event. And you can see that the cerebral vascular event, although important, did not compare to cardiovascular sudden death and other forms of vascular death. I tried to figure out what the other forms were. After going back and rereading the article 5 times, I couldn't figure it out, what other was. But 72% of all the deaths that occurred in this cohort of patients were somehow related to the vascular system. There are 2 large studies. One is called the Inner Heart Study that looked at 15,000 people with acute myocardial infarction and 15,000 controls. And this was actually not limited to the United States, but was worldwide. And then there was a study called the Inner Stroke Study that also looked at 3,000 cases and 3,000 controls, not just in the United States, but throughout the world. And what they found that if you look at the population attributable risk, there are 9 or 10 factors that account for 99% of the risk for developing either a stroke or a heart attack. However, if one looks at hypertension, you can see that the contribution to stroke is much greater than it is the contribution to heart attacks. And similarly, and perhaps this is the reason why it's been so difficult at times early on to prove that atherosclerosis or treatment of lipids were of significance, if you look at lipids, there's a major contribution to the development of future acute coronary syndromes as compared to stroke. So although the risk factors overlap, the contribution of one risk factor compared to another may differ depending upon the vascular bed. I always like to think about stroke versus heart attack. You know, if somebody's got bad hypertension, it can affect the heart in many ways. It can cause a heart attack. It can cause diastolic dysfunction and congestive heart failure. It can cause systolic dysfunction and congestive heart failure. But a stroke is the manifestation of hypertension and hyperlipidemia. There are no other forms of CNS disease that can present from these particular risk factors. And perhaps that's a significant reason why there's been that ongoing controversy as to the role of hyperlipidemia in cerebral vascular disease. Well, this was published in 2002, as I said, 14 years ago. So it was about that time that I actually gave this presentation, I think. And this was the heart protection study, and it looked at people who were at increased risk for coronary heart disease death due to prior disease. And this included people with a myocardial infarction, occlusive disease of non-coronary arteries, or were particularly high risk in the fact that they were diabetic or hypertensive. They were 40 to 80 years of age. Their total cholesterol was greater than 135. And they were randomized to statins, simvastatin 40 milligrams versus placebo. So can you imagine nowadays randomizing somebody to placebo who's had a stroke with regards to treating their lipids? So you can see it's been 14 or 15 years since there's been a significant change in philosophy. If you look at all the patients, there were 20,000 patients enrolled, and 1,800 of them had only cerebral vascular disease. If you look at the incidence of stroke by prior disease, there was a decreased incidence of stroke in all patients. However, if you look at the population who had cerebral vascular disease as the reason for them being into the study, there was no significant decrease in the rate of stroke. If you looked at ischemic stroke versus hemorrhagic stroke, again, the incidence of ischemic stroke was decreased in all the patients. However, if you looked at those people who had prior cerebral vascular disease, there was no significant decrease. Well, and if that's really true, and this was a big study involving 20,000 patients, why treat them? And this is the reason. If you look at major vascular events by prior disease, again, all patients, there was a decrease in major vascular events. And similarly, if you had a prior cerebrovascular accident, there was also a significant decrease in all vascular events. So the body is composed of arms, heart, and head, not just head alone. The next study was called the Sparkle study, and it compared high-dose atorvastatin after a stroke or TIA, and this was published in 2006. And again, this was a randomization between statin versus no statin, unlikely to occur in 2016. There were 4,700 patients who had had either a stroke or a TIA. Their LDL cholesterol varied between 100 and 190. They were randomized to atorvastatin 80 milligrams or placebo. They had no history of coronary artery disease. The primary endpoint was the first non-fatal stroke or fatal stroke, and secondary endpoints included coronary artery disease, and CVD here stands for cardiovascular disease and not cerebral vascular disease. If you look at the curves, if you look at fatal or non-fatal stroke, that was significantly decreased. So unlike the prior study, it was decreased. If you look at fatal stroke, it was also decreased. And if you look at stroke plus TIA, it was also decreased. If you look at non-fatal stroke, there was no significant effect. More importantly, or as important, if one looked at any coronary event or major coronary events, there was a significant decrease in the group of patients who received atorvastatin. And similarly, if you look at cardiovascular events, which include not only coronary disease, but peripheral vascular disease and stroke and heart failure, there was also a significant decrease in any cardiovascular event and any major cardiovascular event. So again, another reason perhaps to rethink the old adage that treatment of hyperlipidemia is actually beneficial. Well, let's look at a population of people who were actually hospitalized with a stroke and look at their use of statins. There's a group that had statin use before stroke. There's a group that had statin use before and during the stroke. Those that had initiation of statins in the hospital. And in all cases, people who were on statins did better than those people who were not on statins. And of additional interest, withdrawing statins on people who were admitted on a statin actually increased the chances of having a complication or dying of your hospitalization. How about a major concern? And the major concern that really was of concern on many of the original studies was the fact that they felt that people who took statins had an increased incidence of intracerebral hemorrhage, and because of that, they were kind of hesitant to use it in people who actually had a stroke. If you look at many studies, both primary and secondary prevention studies, the overall incidence of intracerebral hemorrhage was no different in those people that received statins, either high dose, or those people that received statins and control of no statins. However, if you look at the two seminal studies, the heart protection study and Sparkle, we can tease out some additional information. If you look at the relative risk for an ischemic stroke, you can see both in the heart protection study and Sparkle that there was a benefit in the use of statins. However, if you look at the relative risk for a hemorrhagic stroke in both the Sparkle study and the heart protection study, that there was an increased incidence of CNS bleeds.